All right. Welcome to the Canadian Coalition for Green Healthcare's webinar on baseline results and overview of our heat mitigation solutions. This is for our project on low carbon heat health solutions in care settings. This is a project that is supported by Health Canada. We're really grateful for this contribution. Merci de vous joindre à nous pour ce webinaire sur la ligne de référence et aperçu des solutions d'atténuation de la chaleur dans des espaces intérieurs. Ça fait partie de notre projet sur des solutions à faible émission carbone pour la santé face à la chaleur dans les milieux de soins. My name is William Gagnon. I'm the Director of Implementation for the Canadian Coalition for Green Healthcare, and I'm here with my colleagues on this national project, which is a lot of work, but very exciting. Um, and I'll move us along. If there is at the bottom of your screen, you'll see a caption option for if you need translation to French. Si vous préférez écouter ce webinaire en français, vous pouvez activer les options de traduction simultanée en suivant les instructions ici. Donc, vous devez vous assurer que le bouton bleu, là, le bouton qui devrait être gris, en fait, le soit bleu. Donc, vous avez juste à le faire pivoter. Si vous avez des questions, vous pouvez nous écrire dans le chat. If you have any questions, please don't hesitate to write to us in the chat. The whole team is here to support this webinar. Use a chat function for any technical issues and use a Q&A function for any questions. We'll make some time for a Q&A session at the end, and we might try to answer your questions as we go along. This presentation is recorded and will be put on YouTube for other folks to see after the fact. So our agenda today, we're gonna get a bit of a project overview. We're gonna look at our baseline results. Remember, we've been building this baseline since last summer. We're gonna look at heat and humidity data, our surveys, our interviews, some recommendations, and then we'll be moving to heat mitigation solutions. So what kind of solutions do we want to put in place to deal with the heat waves that are coming, and some next steps and Q&A. I'm joining you from the Ottawa and Dene First Nation lands and homelands of the North Slave Métis. And the work we do here on preparing for heat waves, to me, is really related to our work on reconciliation. I think it goes a step further than just land acknowledgement, but it's also acknowledging the harm and repairing it through climate work. And this is why I do this work, and I invite you to also reflect on why you showed up here today. I think this work is really aligned with reconciliation. Huge team on this end working on this. You'll meet a lot of them today. They'll be sharing our project progress. We have Linda Varangu, Kristen Ansi, Devani Bezinet, Dr. Decams Machino, Raluca, who is not able to join us today, Aggie Black, Dr. Ingrid Waldron, Sarah Kazanovsky, Fiona Parascandalo, Edwin Santosh, and Cromwell Acosta. Thanks so much for joining us. This is a huge project with a lot of partners, notably Peach, Providence Healthcare, Bayshore Healthcare, and Nova Scotia Health. It's truly a national project with the folks from coast to coast to coast. And obviously lots of supporting partners that got us this far. So thank you for joining us in this webinar, and I will now pass it on to Aggie Black, who will give us a bit of a project overview. Aggie,
Okay, wonderful. Thanks, Will. I'm Aggie, and I was kind of introduced in that earlier slide. I'm a registered nurse and a healthcare researcher and consultant, and for this project, I'm one of the leaders for the British Columbia portion of the project. So the objectives for any of you who are familiar with our project, you'll know already that we're aiming to reduce indoor heat health impacts on vulnerable populations. That includes people in long-term care, and we want to build resilience to extreme indoor heat in care settings. We're working directly with healthcare workers, with patients, residents, caregivers, so informal caregivers, and organizations. Our insights are going to hopefully lead to actionable and practical indoor heat adaptation interventions, which we're going to share through multiple types of knowledge translation activities. Next slide. So the scope of the research includes some quantitative data collection. We have data loggers in almost all of the rooms and all of the facilities that are helping us keep track, including most of last summer. We kept track in all the rooms of temperature, humidity, and ambient light. After we do interventions, we'll then be tracking again to see what difference we've made quantitatively. For qualitative data collection, we have created surveys and interviews with residents, with informal caregivers or substitute decision makers, and with staff in the settings across Canada to get an idea of what people's experience so far of indoor heat has been. And then after the implementation of our interventions, we'll see whether people feel a difference in either their experience of indoor heat or for the caregivers and healthcare staff, whether they feel better prepared to respond. Knowledge translation, as I said, is there's going to be a variety of things, including a scenario planning and community workshop. So we hope to share widely what we did and how it worked. Next slide. So the principles the whole project is based on is prioritizing groups that are more vulnerable to indoor heat. So that includes particularly for our project, older adults, people in long-term care homes, and people, some of whom are in their own homes, but still particularly vulnerable. We've engaged Dr. Ingrid Waldron and her team, who are helping us integrate a social justice lens and also guiding our practices and how we're engaging with the communities, particularly when we're engaging with people that face a lot of structural inequity. We're trying to identify interventions that are solutions that are low cost and accessible, low carbon, community and patient safety focused, and reflect real world conditions. So many of our settings for these projects are older buildings where we can't necessarily do all the interventions we might want to do. So we're really focused on what we can do that's practical, that reflects the reality of those settings. And we're doing lots of partnership development and being very transparent about what we are able to offer and how we want to partner with people in this project. Next slide. So this is a timeline of the whole project. We are approximately at the about to do heat interventions. So you can see that we've done the baseline data collection, both quantitative and qualitative. Last summer, we're now at the point of working with, at least in BC in particular, we're working with leaders in our two settings to determine what intervention is going to work best here. And then we'll continue the measuring of quantitative data, the heat and humidity, and we'll move forward into the intervention and then talking to residents, substitute decision makers, and healthcare workers again. So I think I'm now turning it back over to Will.
Thank you so much, Aggie. So now I'm gonna do a quick overview of our baseline results. So as you remember, we have data loggers in home care, long-term care, and hospital rooms across the country. So in Vancouver, in Hamilton and Ottawa, and in Halifax, we have about 250 data loggers continually measuring temperature and humidity at all of those sites. So about half of them are in long-term care facilities. 21% of them are in acute care, 9% in home care, 11% in rehab, and 10% in other settings. The devices look like this one here on the right. So it's a little white box called a UVBot WS1. It is Wi-Fi enabled and it measures temperature, humidity, and illuminance, so light level. It has a little battery, and a AA battery, and a USB cord. It can work on either the USB cord only or the battery only. And it is connected through Wi-Fi. In some cases, we're not able to use a local Wi-Fi, so we have to use an iPhone. We create a hotspot with the iPhone to go and collect the data. So the data collection is a challenge in itself. So this is for Hamilton, Ottawa. In Halifax in British Columbia, we have a system called Lower One. It's a system that Providence Healthcare was already using. It's working pretty well for data collection as well. So I'm going to go through some of that data. This is what it looks like on our end, so we can see each room. Here you can see on the second line 2.2 volts, meaning that the USB was probably disconnected and the battery's dying, so we have to go and reconnect those regularly. It is a lot of work on on Kristen mostly to make sure to chase those data loggers that go offline. Sometimes the USB cords disappear. We don't really know why. We suspect some of them are required for personal use, and so the USB cords disappear. It is a real challenge to install those data loggers, and I'm grateful that we made it so far. Um, so this is the data in Vancouver. The red line is the exterior temperature from Environment Climate Change Canada's that is at the Vancouver International Airport. And the purple lines from white to purple, this is the 50, 60 something data loggers that we have. And as you can see, a lot of them are in the 20 to 25 degrees Celsius range. Some range from 25 to 30. Some go above 30 degrees. This is not the wet bulb temperature. This is only the actual temperature because we were missing some humidity data in Vancouver. So I decided to show the data in actual temperature. But basically, hotter indoors and outdoors during peak summer months, which reinforces the need for shades and better ventilation and whatnot. So this was in Vancouver. This is in Halifax. This time, this is wet bulb temperature. So I'm using the equation by Stull, Stull, to estimate the wet bulb temperature based on the temperature and the humidity. Again, here, red line is the exterior temperature at Halifax International Airport. And the blue lines from white to blue, as you can see, there's a bunch at the bottom here. They are all data loggers in different, I was going to say hotel, I mean hospital rooms. And you can see that some of the peaks are kind of related to the exterior temperature peaks. We are definitely in the moderate heat stress zone here at some point. You'll see that it is not as high as the previous graph for Vancouver, but this is adjusted for indoor wet bulb temperature. Um, we were only able to start collecting data in June, and not for all of them. Most of them came online in July and August. So I'm actually looking forward to April and May. Um, and obviously, as we go down in exterior temperature, the temperature inside also drops. Next, we have Ottawa. It took us a bit longer to install those data loggers in Ottawa because none of us were physically in Ottawa, so we had to find some willing partners, which we did. Again, red line, it's the exterior temperature at Ottawa International Airport. And the green line is in those care settings. It's mostly home care in Ottawa. We can see that some of them are entering the moderate heat stress, but that was in late August. So looking forward to see what it's going to be next summer. Finally, Hamilton. Data collection started late September, so we can't really tell from what we have right now, but some of them are already in the moderate heat stress zone, even in October. So we can imagine that this is going to continue showing some risks in the new year. So the challenge is keeping the data loggers connected at all times. In Halifax, most of the building, and Kristen might correct me if I'm wrong here, most of the buildings are on iPhone hotspots. We have an iPhone that we ask either Kristen or a volunteer to move around the buildings and to connect to those devices and collect the data. This is manual work that takes time. And in Ottawa, mostly those devices are connected to personal Wi-Fi. In Hamilton, I believe they are on Linda's iPhone, and in British Columbia, it is collected directly to the facility's Wi-Fi. So just the retrieval of the data is a really time-consuming and technically challenging process. When the USB cords are disconnected, then the batteries start to drain. So we have to make sure that somebody walks around those those devices and replaces the batteries when the time comes. Um, Now that we are collecting this data, it's interesting. We can start putting some alerts for high temperature zones. My inbox and Kristen's inbox is filled with alerts of high temperature zones. Some of them we investigated, they were too close to a fridge, for example, and the heat of the fridge would trigger temperatures above 30 degrees Celsius, mostly in mitigation rooms or staff rooms. So this data, even if we haven't, we're just not even halfway through the process here, but it's really allowing us to um, get a pulse of what's happening. We're already working with some health authorities to implement heat mitigation solutions. We'll talk about that in a little bit. That could mean shades or LED lights or photogrammic filters and whatnot. But we'll discuss this at length. And now with this, I will pass it to my colleague Kristen for patient and resident and healthcare worker surveys. Kristen.
Thank you, Will. Can everyone hear me all right there?
Yep.
Great. My name is Kristen. So I'm going to go through some of the survey results with you to begin. So we'll start with the national results. This is compiled across 158 surveys with healthcare workers in all 3 provinces. So if you look at the first graph there, you'll see that one of the questions we asked these folks was, have you experienced high indoor heat that was so high that you were uncomfortable in the last 5 years? We had a pretty good response rate to this question. And as you can see, the majority of them said yes to this question at their own facility. It was not as common for them to have not experienced it at their facility. This might have something to do with the fact that we did target hotspots and we did try to find healthcare workers that were experiencing this so that we could have more relevant data to find out what their experiences were. But then even at other facilities, it's still pretty common for them to experience high temperatures. When we look at whether or not it made their job more difficult, that becomes even more apparent. It's very rare for anyone to say that it made their job easier. A small percentage, 10%, said that it didn't have an impact, but the vast majority of the healthcare workers said that it made their job more difficult. Go to the next slide. So another question we wanted to know was how many of these professionals were working directly with older adults, and that was 80%. So we had a pretty good response from folks who have experience working directly with older individuals. And then another important question we wanted to know was how prepared they felt. So as you can see, you know, it's pretty common for them to say that they don't have adequate tools. They're 29% are saying yes, they have adequate tools, but the remainder are all saying either no or they're unsure if they have adequate tools to address heat response in their facilities. There is a higher amount that believe they have adequate knowledge at 48%, but that still means that the remainder, above 50%, are either saying no or they're uncertain about whether or not they have enough adequate knowledge to address these issues. So those were important just for understanding how prepared everyone feels. And I think we can say that they probably don't feel as prepared as we'd like them to be. We can go to the next slide, please. So looking at the patient and resident surveys, we have the majority of our participants. We did 90 surveys with patients and residents. 43% of them were in home care, so that's all the Ontario. Everyone in Ontario is home care. Whereas we had the next largest group was long-term care. There's a lot of long-term care residents in BC and in Nova Scotia. And then the next largest group was acute care. We have 21% acute care in Nova Scotia. And then the final was 7% in rehabilitation settings. It was pretty common for them to say that they had experienced indoor temperatures that made them uncomfortably hot in the last 5 years. So 61% said that they had that experience. Keep in mind that a lot of these folks may be elderly and they actually typically experience feeling too cold as well. Then out of 55 participants who had experienced uncomfortably hot temperatures, 47% of them reported receiving help, while 53% reported not receiving help. So that's a pretty high number. It should be noted that that was typically more common in home care situations. If someone was in a facility, they were more likely to report feeling helped. And then finally, we wanted to know who was helping them. And these results did vary, but overall, across the national results, patients were more likely to actually say they reported assisting themselves. They often would say they helped themselves. That would then be followed by a family member, then care provider, and then volunteers. Interestingly, nobody responded to the friends category. So we're not sure exactly why that is, but it's an interesting question to ponder. We can move on to the next slide. And then another key group that we did try to reach out to was SDMs. Unfortunately, they were a really difficult group to reach this year. So we only had 6 surveys and 2 follow-up interviews with SDMs. So it's a pretty small data set. Out of that data set, we did find that they typically would say that care recipients have been helped by family members and care providers during high heat incidents. So that kind of conflicts with what the patients themselves were saying. So it's such a small data set that we can't really make any broad conclusions, but it is an interesting finding, a very small pattern that might help point us in the direction of future research and questions we could ask that might impact patient care. So we can move to the next slide, please. Then looking more targeted at the surveys in different provinces. BC, the site BC, we had 9 residents that we did surveys with in long-term care, and they were actually less likely to have experienced high indoor temperatures that were so high that they were uncomfortable. This may have something to do with medical conditions or the facility itself, but those who did say that they had experienced high temperatures were also likely to say that they had experienced assistance in those situations. We can move to the next slide. So the healthcare workers in BC, it was common for them to have witnessed impacts of high indoor heat. So they often would report saying they had experienced this on residents and healthcare workers. But what I found interesting was also that there was a fairly large group at nearly 30% who had said maybe or unsure to this question. Now, this wasn't just in the BC location, it was also in some of the other locations as well. Maybe and unsure was a common statement to make to this question. And so it just kind of highlights that perhaps more awareness, more conversation around this topic would be helpful. We can move to the next slide. In the Halifax sites, it was very common for people to have experienced high indoor heat as well at 60%. And we had 42 patients and residents that we spoke to in Halifax. For those who had experienced being uncomfortably hot, they also stated that they had been helped to be more comfortable as well. So we can move to the next slide now. However, it was really interesting. The healthcare workers, out of the 86 healthcare workers that were surveyed, 77% said that they were not confident that they had adequate resources and tools to address high indoor heat, which really mirrors the national results. This is not uncommon. I think it's safe to say that a lot of healthcare workers feel like they could use more support in this area. Go move to the next slide. Now, in Ontario, the Hamilton and Ottawa locations, these are all home care recipients, and it's quite a different story. We have 69% saying that they've been uncomfortably hot in the last 5 years. And out of those who have been uncomfortably hot, 85% reported not receiving assistance. So this really reflects the isolation that they're experiencing. Many of them may have some home care workers coming like once a week or something, but they're not living in a situation where they might have as much access as some of the other participants in the study. And that was 39 participants in Ontario that we were able to survey. Can move to the next slide. We had a smaller group of healthcare workers in Ontario. So it was a small data set. It was a bit difficult recruiting there. However, out of that group, we have found that 71% were confident that they had seen high indoor heat on the residents, and another 43% were uncertain if they had seen effects on staff. So it actually was more common for healthcare workers to not be certain if they had seen something on staff. They tended to be more sure that they had seen something on a patient, but not staff members. So that was an interesting finding as well. We can move on to the next slide, please. And so I'm going to pass things over to Sarah now to discuss our interviews and the findings there. Thank you.
Thank you, Kristen. Hi, everybody. My name is Sarah. And as Kristen just spoke to the surveys, I will be speaking to insights from the 80 interviews that we conducted in 2025. So the individuals that were interviewed are of the same groups that Kristen just spoke to regarding the survey findings. So if we turn to the first slide, thanks, Will. As this slide shows here, there were 3 key findings that emerged from the interviews. So the first one here, there is a gap in healthcare worker readiness. So to show this, 68% of healthcare workers reported feeling confident in recognizing the signs of heat stroke. So clearly, while many of them were confident, this also points to a confidence gap. And at the same time, 80% expressed interest in receiving additional training on heat-related risks. The second finding, there was an obvious need for cooling. More than half of participants, so 55%, called for improved air conditioning or cooling systems. And also over 30% also identified fans, window shadings or curtains, and increased staffing or monitoring as critical strategies for managing indoor heat. And then the third finding, we were able to better understand patient and resident needs. So the interviews that we conducted highlighted pretty clear vulnerabilities, where 17% of participants reported needing assistance to cool down during periods of high indoor heat temperatures, and 15% of them actually reported having been hospitalized due to extreme heat. So if we turn now to some of the experiences of the different groups that were interviewed, we will start with resident and patient experiences. For patients and residents, they described heat exposure as common and an ongoing reality. And also they highlighted that it was structurally produced rather than just an occasional inconvenience that they experienced. Nearly 2/3, so 63% of patient and resident interview participants reported experiencing high indoor heat within the past 5 years. And to respond to this high heat that they were experiencing, most of their strategies that they described were self-directed strategies. So things like using fans, air conditioners, drinking cold fluids, taking showers, just different things that they could do personally to cool themselves down. The next group, at the next slide, if we turn to staff and healthcare workers, their experience with heat and how they managed this through different strategies, they acknowledged that it is a real and recurring risk in care settings, but formal preparedness measures and guidance are insufficient. So most respondents, 80%, reported that they were aware that their organization does issue heat or extreme weather alerts, but fewer than half of them, so 36%, were aware of an actual heat plan for their setting. And too often with staff members and healthcare workers, the onus is kind of put on them to find this information on their own. So reading posters or memos or sifting through emails. So yes, that is something that they reported in their interviews. If we turn now to the SDMs, um, they described their concerns as rooted in everyday vulnerability rather than just a one-off or exceptional situation. So they were describing their concerns that included whether being concerned whether their relatives would recognize or respond to heat stress on their own. They also had concerns about frailty, wheelchair use, limited mobility, and reliance on others for hydration. And they recognized that risk was seemed to be managed just in time through informal care instead of having formal protocols in place. If we turn to vulnerable groups, the next slide. So most interview participants emphasize that basically everybody in these care settings are considered vulnerable. However, they did recognize that there were elevated risks for particular groups. So, for example, older individuals, people that have complex or chronic health conditions, that aren't able to communicate their discomfort, people, for example, on medication that increase their heat sensitivity or increase their risk to dehydration. Staff were also seen as very, very vulnerable, especially those who are already engaged in physically demanding work. And this year, we're also going to be doing 30 targeted interviews, 10 in each province, where we'll be identifying individuals who are particularly vulnerable outside of healthcare settings and finding out what their experiences are like at home. So, more to come on this section. And next slide, turning to infrastructure and policy gaps. So, some gaps that were found through the interviews were a lack of awareness of available resources, limited confidence in institutional support for managing heat, as well as minimal formal guidance on what to actually do during these heat events, under-resourced staff, and patients and residents, many of them perceived that the staff were overworked, so they were less likely to ask for help just because they figured that these staff members were already so busy. Unequal access to cooling and insufficient equipment. So next slide, yes, overarching insights. So turning now to some recommendations. If we turn to the next slide. So these were some of the recommendations that were provided from our interviews. So we kind of broke them down into different sections. So at the building and infrastructure level, a recommendation was that it's recommended to treat cooling as essential infrastructure, not just a luxury, and to provide room level cooling. So not just having cooling in hallways and offices, but in the rooms as well, and to improve windows, shading, and air movement. At the policy level, it was recommended to develop formal and site-specific heat plans that clearly spell out roles. In terms of staffing, standardizing bedside cooling actions. So this could look like a simple checklist to go through for staff. Training, providing regular brief heat health training for staff, and moving beyond just this experience of reading the memo or reading the posters that might be on the walls, but having proper training embedded into staff expectations. And then autonomy, expanding resident control and autonomy over temperature. So, for example, in their rooms, having control over that. And finally, for data, tracking heat-related events systematically. So this could look like logging heat-related symptoms, logging transfers to hospitals, resident complaints, and staff incidents during heat waves. We'll be sharing more of these recommendations at the end of the study, but I will turn it back to Kristen to continue on with some recommendations.
Thank you, Sarah. Okay, so I'm going to just cover the BC slides team slide as well quickly because Raluca can't join us today. So from their experiences in BC, there was some recommendations that was provided by the BC team. One of the first recommendations was to have intentional engagement with all of the groups at every stage, so that staff, patients, residents, and SDMs to get a good idea of their experiences. They also felt that having annual education initiatives on units in relation to heat prevention would help to equip professionals to feel more prepared for heat events as well as during and after the heat season. The third recommendation that they gave us was planning for clinical heat mitigation solutions. So how this needs to be balanced out with what the reality is in these buildings and what the infrastructural conditions will allow to be available. So an example of this is limited power grid availability in older sites. Sometimes it limits what you can actually do. They feel as though the climate vulnerability surveys provide really good information to help with future climate impacts. And finally, using a multidisciplinary project team lens has been very helpful to them with the holistic approach for different phases of planning through the project. We'll go to the next slide. So some recommendations from the Nova Scotia and Ontario team. Looking back at the engagement, the interviews, the surveys, and all the meetings, there are some things that came up that really resonated. So I wanted to share some of these recommendations with you. The first is that temperature regulation in general is an issue. So echoing what Sarah said about autonomy is very important. When the building is you're having the temperature controlled by others and you don't have the ability to adjust your thermostat in your room, it can be a very frustrating experience for people. But also convenience is very desired as well by staff, particularly because they're overrun and they're busy. Having things like remotes and timers automated could really help with some settings to assist them, particularly with like sunshades going up and down at peak sun. So that's an example. The next thing that really resonated was that there's just no one size fits all solution to these scenarios. All the different units, different floors, they house people with different conditions and different settings for various reasons. So there's going to be sometimes different rules on some of these units, which means that each unit may need to tailor their solutions depending on what they're allowed to do and what's safe for them to do and what they have funding to do. As well, I noticed that there's a strong desire to advance through unions and health and safety lens. I've started working with occupational health and safety more and more because it seems as though this is a really good path for moving things forward. So there's this desire to move things forward in the current systems through that mechanism. As well, the importance of making tools and resources and education actually accessible is so important. Some cases, they actually have this stuff, but they don't even realize that they have it. So making it more accessible and people more aware of what is available and developing new resources is very important at this stage. And then finally, some of the findings that I saw from the surveys, there was a bit of inconsistency on some perceptions from shared by different groups. This could be for a variety of different reasons, and it's hard to say at this point why. So again, I feel as though, is it have something to do with recollections being inaccurate or outdated, or does it have something to do with different experiences in general? Could it be the data collection method we used? More in-depth research would help to answer some of these questions that are starting to arise for us. So going to the next slide. So moving into the heat mitigation solutions, I'm going to go through a list with you. We can go to the next slide for that. So we had a huge list at the beginning of this project, and it's been winnowed down slowly over time through multiple engagement sessions and meetings with folks. So some of the top ones that we're looking at right now are the cool kits. They contain things like water bottles, ice packs, cooling towels, thermometers, and fact sheets. So those were really quite popular, and they can be used in a variety of different settings, including when patients are discharged to take home with them. Healthcare workers found them to be useful. They think that it would be great to try them out, as well as patients. Mentioned before, the roller shades, especially automated with remotes and timers, was a very popular option. So we're looking at prices for that and looking at how many we can afford to do that this year. As well as blackout curtains, blinds, and window films. Basically anything that could help to block the sun out. People are interested, but it does vary based on the context and the preferences of different groups and what they're allowed to do at their facilities. Fans is another important option, but not in acute care settings because of infection control. So in some cases, we'll be able to distribute fans and see how people find them. And we have a variety of different fans we're looking at right now. The education was also very popular. The idea of having fact sheets. We really wanted to tailor this to different audiences to make sure that it's appropriate depending on the setting and the group. So we're working right now to do specific fact sheets that are tailored to healthcare workers and family caregivers and patients and residents and managers even, so that they have the information they need. And just a quick note, people were interested in courses, but it's very difficult to find courses that are tailored specifically to this topic in these groups. So if anyone has any suggestions for us, we'd really appreciate you sharing that with us. We're going to give you our contact information, and we'd love to hear about options that you think, whether it's organizations that might be able to help create videos or courses, or existing resources that you already know of. And then the next option that was really popular was policy. So risk assessments and heat mitigation officers, and kind of embedding this into processes in a long-term way so that there can be a continuity and tracking this over time and progressing was another popular option. Increased water access. We've had folks ask us about coolers, pitchers for patient rooms, large insulated jugs for group events. So we're looking into all of those options for different units, as well as scrubs with cooling fabrics. In particular, like some healthcare workers have their scrubs provided and others don't. And there was an interest in having something like this integrated into existing systems, and maybe even advancing it through unions to make sure that people can have access to cooling scrubs. And finally, the cooling vest. I kind of refer to this as a bit of a niche option because it's really intense. It's like strapping a bunch of ice packs to your chest. So it might not be great for everyone, but in some cases, it could be really helpful during a heat wave. So we can move to the next slide. So there were a number of barriers and considerations when talking to people about the heat solutions. I kind of made a list here of just like the key ones that came up over and over again. So with multi-unit buildings, there are bylaw requirements to heat buildings, but currently there's not often any requirement to cool them. This is something that's starting to develop, and cities are starting to catch on to this, and there's movement in this area politically, but at this point, that's a barrier, as well as rules around conformity. So not wanting the outside of the building to look different to other units or other windows can be a barrier. It's quite expensive to retrofit every single window, especially if you're just trying out something. So that's an issue. Then there's also the large facility requirements. So things like not being allowed to open windows for air quality control and infection control, or even just older infrastructure. Sometimes people will say, well, we're going to retire this asset, or, you know, the electrical grid is old. So those things can pop up and make it difficult to make some changes and retrofits, as well as the long-term maintenance costs. Sometimes they will say, well, that's great now, but who's going to maintain it in, over time, right? Finally, there was different contexts with work settings and with residents and patients that could sometimes impact how open people were to trying new solutions. Things like group settings, remote controls, the confusion that some patients might experience, or the potential to damage items depending on which unit you're on, were all something that healthcare workers particularly would bring up and say, well, we don't know if that's going to work on our unit. Then there was the approval processes, which can be quite lengthy because of safety concerns. So sometimes that can impact uptake. And finally, staff sometimes would show concern around having their workflow modified and if it would be something that they could accommodate. So these are all things that came up as barriers. Move to the next slide. And I'm just going to pass it off to Will now to talk to you about our next steps. Thank you.
Thank you so much, Kristen, for all these gold nuggets of data. I would like to encourage everybody here to use the Q&A function. If you have any questions or comments, please use the Q&A function, and we'll be answering those shortly. So our next steps here is our continued engagement with site management and staff. We want to identify which solutions make the most sense, which could we try, where we want to try as many heat mitigation solutions as possible. We want to make sure that we have some control rooms as well to really see their performance. Some of those mitigation solutions, we will see a reduction probably in indoor temperature, while some of those we might not see a reduction in indoor temperature, but we might see a reduction in perceived indoor temperature. We are still engaged. Our window for engagement with partners and sponsors for heat mitigation solutions is still open. So if you are connected to a business that has a solution that'd like to trial them with us, we're very keen to take on some sponsorships. Please don't hesitate to connect with us if you'd like to learn more about that. We are moving very quickly to the implementation of those heat mitigation solutions. So we're basically planning, okay, where are we going to install curtains? Where are we going to install shades or photochromic filters or 12-liter jugs of water? That will take most of our time in the spring, summer 2026. We'll be collecting follow-up temperature, humidity, interviews, and surveys in the summer, so we can see the performance of those heat mitigation solutions. And finally, if you have any questions, if you'd like to get in touch with us, if you'd like to collaborate in any way, please don't hesitate to get in touch here. And I will now pass it to our showrunner extraordinaire, Devaney Bezenet.
Hi, everyone. Thanks so much for joining us today. We hope that this was just a wealth of information. We are so excited to be able to share the incredible work that's been happening over the last year. So I'm just going to run through the questions that have come through. Please continue to put them in through the Q&A function. There was a question that had come in about the brand and number of the data loggers, the monitors that we were using in each of the different rooms. And so Will provided a great answer to that. So if that was a question you had as well, please refer to the Q&A. Will's answered that. But I do have a question for I'll pass it over to Kristen. One of the other questions was, do we have healthcare workers in home care situations as well? So if you want to speak to the situation in Ontario.
Sure. Yeah, actually, we do have healthcare workers in Nova Scotia as well that do go to home care. We didn't go into home care settings in Nova Scotia, but some of the healthcare workers, they move from location to location. So some of their experiences would be relevant to home care, as well as the Ontario healthcare workers would have experience relative to home care. Thank you.
Great. Thanks, Kristen. Okay, so one of the other comments that had come through was actually a member of our Canadian Coalition for Green Healthcare team, Alex Hutton. So she's noted that displacement ventilation is a strategy to passively remove excess heat from spaces. So maybe Linda, I'll have you sort of on deck ready to answer this question, our senior advisor for the project. It's not necessarily, Alex acknowledges, a simple fix, but it could end up being a very effective and cost-effective solution in certain circumstances where existing conditions are conducive to such a retrofit. Linda, did you want to speak at all to displacement ventilation and maybe how this would sort of fit in with some of the insights and the types of solutions that we've been thinking about?
Yes, hi, and thanks, Alex, for the question. It has been on our minds because this is it's a novel approach. People often don't think about this as a possible solution for removing excess heat from buildings because it also accomplishes other things as well. And so it's a technique where the excess heat would be removed from the building and allows the building to be cooler. And so, Alex, if you want to jump in, please do so as well. It's um, it's something that we've been thinking about for a while, and also it actually helps reduce carbon emissions too. And we recently had a tour of one of the buildings that is using this technique in the Toronto area, which a number of healthcare workers in the Toronto area were able to attend. So, yeah, if we are making recommendations to healthcare facilities on opportunities to not just save on their carbon emissions, but also to reduce the excess heat in the building. And I think Alex has, okay, not sure if I can jump in. Can we unmute Alex? Alex is also saying that it was just a reminder so that we make sure that we continue to have this as an option going forward for facilities should they want to worry about it. Sorry.
Thanks. No worries, Linda. Anything else you want to say on that? We move to the next.
Yeah, we can move to the next.
Wonderful, thank you. Well, those were the questions that that had come through. As was mentioned at the beginning, this was recorded. We will make this accessible, including the slides, to all those who registered. But of course, this will also live on our website and our YouTube page. We are here to answer any questions after the webinar as well. Very, very happy to do so. Very happy to keep the partnership conversations going and growing. But just a big thank you to everyone who took the time. We are always here for any questions. And I hope you have a great rest of your Tuesday afternoon. Thanks, everyone.